So like Craig said, there we go, it's on now. My PhD was on that topic, and there was no direct link to patient-centeredness in that PhD, but what I'm hoping to convince you today is some of the findings from my research can be applied to the way we go about our practice and the way that our practice is directed by a whole bunch of things that we sometimes aren't really aware of. So I used a method, oh sorry, I should go across to the first thing. I used a methodology called institutional ethnography that started, the purpose of that is to try and establish what's guiding the way we practice, what systems, what relationships, what documents, what processes exist to determine how we go about, how we're directed, how we're forced even, guided to go about. And what I guess the value of that is in relation to person-centeredness, is trying to establish, like Brendan was talking about, that notion's been around for a long time. There's issues with that being sort of taken up, and what are the barriers to that. So I guess my presentations today is about trying to maybe explore some of those barriers around the way that we work and the way that we're required to work that get in the way of us either being able or being willing or actually focusing our nursing practice from that person-centred approach as well. So just before I go on, I'd like to say I acknowledge the First Nations people, and it's really important, I think, to recognise that they were the original researchers, they were the original clinicians, and they were the original educators of these lands, and we've got lots to learn from them as well. So with that, I guess sort of background, part of what I was looking at is what about our system, the way that the healthcare system, the practices, the policies is at work to create this sort of potential disconnect between what happens locally and what's directed more centrally, and it's recognised that, you know, in a big complex system like healthcare, there's going to be these disconnects between what one group or what groups of people say we should be doing and what's happening, and there's good reasons for that disconnect, but trying to understand those is really useful if we want to make change. Because Brendan was talking before about, you know, often we're trying to solve a problem, but if we don't understand the problem first, then we're not really going to get very far with that. And part of, I guess, my argument or the way I approached this research was an understanding that sometimes when we're practicing at that local level, we're not fully aware of the other factors that are having an influence on us. So articulating that or exposing that and discussing that is a really useful way to approach, you know, a big problem like this, I guess, as well. So I don't think there's this bubbling thing of people don't want to give care that's focused around the patient or focused around themselves. I think there's things that get in the way of that, and I guess that's part of what I'm going to talk about today. So when I'm talking about policies and practices and the things that guide our practice, I guess that, you know, there's good policies and they're intended to, you know, try and keep people safe and have consistency in care, but there is this tension in healthcare, and I'll be talking about nursing, but I suspect this applies to a whole range of different healthcare disciplines. So it'd be interesting for the midwives in this room to say, you know, does this also resonate with us as a profession or a specialty as well? So even Patricia Benner back in the 1980s was talking about this. There's this sort of tension between, yes, we do want to and we need to, and there's value in providing patient care that's individualised to that person in that context, but also we need to have minimum standards. We need to have some sort of consistency, because if we just let anyone do everything, then it'll be anarchy and, you know, it'll be terrible. But I think there is this tension balance between those two things. And I think what's happened over the time is the pendulum has swung a little bit too far towards that standardisation, and what that has made occur almost imperceptibly, because it's happened so slowly over time, is that individualisation of person care has suffered. And I think we may not fully recognise how and why that's happened, but I think that actually has happened, unfortunately. In terms of, I guess I just quickly put this slide in because even the Commission on Safety and Quality recognises that the way we're going about doing things like assessment and documentation is a little bit problematic, and has resulted in a whole range of unintended consequences as well. So there's a lot of text there, don't need to read it all, but I guess the notion is that they recognise that there's burden, there's actual unintended consequences that are creating additional harm. You know, we've shifted towards this tick box compliance sort of approach, and we risk losing our clinical judgment in practice as well. So one of the ways I'm obsessed by Desire Pass, so unfortunately I put this in there. One of the things, I think the value of looking at Desire Pass is we start to think, okay, we've got this system, we ask people to do it this way, but they're doing it a different way. Why is that the case? What about the way we ask people to do things in healthcare is not meeting their needs, or they're not finding that useful? Is it because they're slack and they're lazy, or is it because the way that we ask them to do it is not working for them? And I think the notion of Desire Pass, which in urban planning is, you know, a path where, you know, people tend to walk and create a path because it's, you know, quicker or more efficient for them, is really useful. So in this example, if we apply this to healthcare, and we think about what happened in this picture, that there was originally a Desire Path there because people wanted to take a shortcut, they could get there wherever they were going more efficiently, more quickly. And so then the planners recognised that, they put this stepped pathway in, but then people didn't use it. They walked on the other side. So yes, the people in charge recognised that, they did something, but it didn't suit the people's needs and they still did something else. I think that's a really useful way of looking at healthcare, is understanding what's going on, how is that going on, why is that going on, rather than just going, oh, that's a problem, let's fix it. Let's try and understand it a little bit better as well. So there's a whole range of unintended consequences that do occur in some of those practices, and like I said, that happens slowly over time, and what that can lead to is it becomes quite burdensome for people delivering care and frustrating. So all those additional documentation requirements, compliance requirements start to build up, often in a very uncoordinated manner, because over time they're getting contributed to and no one's sort of overseeing that and understanding what the impact of that is. And so what I think is happening is that shift in focus away from the patient towards that sort of documentation, compliance, all that sort of stuff, starts to reduce nurses' capacity to be able to deliver care and to focus on the patient. So they start to move their focus from the patient towards maybe the screen instead, unfortunately, or the paperwork if you've still got hard copy sort of stuff as well. So I think that risks a reduction in the capacity for people to connect in care, and also that risks their ability to think critically, because they're being led sort of in a very process-driven tick box sort of approach as well. So it's useful to look at how we're practicing in terms of how we go about interacting with people, how we practice, and look for the little hints for any desire pathways in that as well. So I guess over time that shift in emphasis has moved towards that sort of compliance and that process-led practice rather than what's the purpose of what we're doing. And that's why I included those things in the title, because I think and we do this in education as well in universities, is when we tend to get distracted by how to do something rather than why are we doing that. So we head off into the how and talk about how to do something in the process of doing it, but we don't spend time considering and understanding and exploring the purpose first, because that's a little bit harder to do. But the problem is if we don't spend time doing that, then nurses' actions and care starts to be really framed around process rather than what they're there for, what's the purpose of doing this. So especially if they're doing documentation, it becomes the purpose of ticking those boxes, filling in those questions, rather than what am I trying to achieve here. So in my research, I would hear nurses talk about doing an admission, and that may be a really common phrase, but what I saw in that was they described that as a process. So you're doing an admission, you're not assessing someone's needs and identifying their risks. So even by the way we frame and we talk about things, sort of directs how we go about doing our practice. And over time, that sort of shifts our attention away from that process, and we may be losing the importance of establishing those relationships and really discovering important information in that care as well. So there is a risk that yes, we end up treating the screen. So as nurses' attention is drawn away, they start to focus on the documentation and they fail to engage with someone on a humanistic level, get a really good understanding and establish what they need to do from that as well. One of the things that I found really interesting lately, this is a paper from the New England Journal of Medicine, is getting rid of stupid stuff. And it sounds a bit silly, but the concept of it is challenging our practices. What do we do that doesn't seem to make sense to us, or the way that the nurses are practicing, and starting to go, no, this is not useful, I think we should be doing something different, and start to work through why that's important and how to go about doing something different as well. It's important for us to focus on how our practice is designed, what's it influenced by, and then that gives us capacity to start thinking about what can we do differently, what systems can we change, what requirements can we get rid of, what things can we adjust to start to add the capacity to nurses so they have an ability to start, doing the things that make more sense to them in a way that makes more sense, because we often ask nurses to do things exactly the same. So we have this pressure to do things consistently and everything is standardised, but we have nurses that's their first day as a TPPP, and we have nurses who have been working for 20 years who are working at expert level, and we require them to do things exactly the same way. Now, does that make sense? Probably not, but how do you go about allowing that sort of variation and flexibility? But it's something that we need to consider. I think there's real value in that, because we can improve nurses' satisfaction, we can prioritise that human experience in healthcare, and we can also, it's not just about being nice and having a better experience. From my research, if nurses have more capacity to spend time with patients, then there's much less likely to be adverse outcomes associated with inability of nurses to spend time with patients. So, they're more likely to have their pressure area care done. They're more likely to understand if they have mental health issues, if there's problems with nutrition as well. So I think there's a very significant value in spending time and freeing up capacity of patients as well. So what I recommend is looking for the stupid stuff in our work, so then we can challenge, change or continue it. So it is sort of our choice, but we are influenced by the systems we work in. So I think looking at this from a very broad conceptual systems level is really important as well. And so I think if we can free up nurses' time, free up their ability to focus on what really is important in nursing, then we have the ability to try and connect more closely with people in care and have a whole range of positive outcomes associated with that as well. There you go. Oh, that text's not very good, sorry. And that's it. Thank you very much.